Okay, so the thyroid gland, as you can see, it is present in the neck in front of the larynx and in front of the tracheal rings, butterfly shaped structure. It consists of the right and left lobes connected by a narrow isthmus. So it has two lobes, right and left lobes, and they are connected together by a narrow structure called as the isthmus. Isthmus. Each lobe is pear shaped with an apex and a base. If you see here, so each of these lobes, these are the two lobes of the thyroid gland. It looks like a pyramid with an apex on the top. So this is the apex on the top, and this is the base. So on either side. Okay. So it looks like a pyramid on either side. The apex rests on the thyroid cartilage, reaching its oblique line. If you see here, the apex reaches up to the oblique line. This line is called as the oblique line on either side. Okay, this is the thyroid cartilage. So this is the oblique line, and this is the Adam's apple, the angulation between the two cartilages of the thyroid joined together in the front. Okay, so this is called as Adam's apple, and this is called as the oblique line. So this the apex reaches up to the oblique line of the thyroid cartilage. The base reaches the level of the fourth or fifth tracheal rings. If you see here, so the base has reached up to the fourth or fifth tracheal ring. These are the tracheal rings. These are trachea, and these are called as tracheal rings. So it reaches up to the fourth or fifth tracheal ring. Okay, and the isthmus crosses in front of the second, third, and fourth tracheal rings. And if you see here, the isthmus is slightly higher up, and this will cross at the level of second, third, and fourth tracheal rings. The pyramidal lobe may project upwards from the isthmus. Sometimes there is an additional lobe called as pyramidal lobe, which might extend from the isthmus. Okay, it is not exactly in the midline. It will be slightly toward the right or left side. Okay, so this is called as pyramidal lobe. May project from the upward from the isthmus. So it is projecting from the isthmus. Then we have something called as levator glandulae thyroideae. So this is a fibrous or muscular band connects the pyramidal lobe to the hyoid bone. So this pyramidal lobe is connected to the hyoid bone. Hyoid bone is here. So by a thin fibrous or muscular band called as the levator glandulae thyroideae. This is important because whenever you swallow at that time, this connection between the thyroid gland and the thyroid gland as well as the hyoid bone by this levator glandular thyroideae will pull the thyroid gland upwards. Whenever the person swallows, the thyroid gland, the hyoid bone moves as well as even the thyroid gland moves upwards. Okay, so this we can be a good sign if you want to locate any mass in the neck. If the person swallows and if it moves, then it should be from the thyroid gland. Okay, so this is clinically important to see the movement when swallowing. Coming to the relations of the lobes. Okay, so if you see here, this is the thyroid gland deep under the muscles. So what are the relation? Anterolaterally, we have the sternothyroid. Sternothyroid. So there is a muscle called as this is the sternothyroid. Okay. Then the superior belly of the omohyoid. So this is the superior, this is the inferior belly, and this is the superior belly of the omohyoid, which is in front of this thyroid gland. So it is deep under the muscles. Then we have the sternohyoid. So this long muscle, this is called as the sternohyoid because it is going up to the hyoid bone from the sternum. Then we have the anterior border of the sternocleidomastoid muscle. Then there is a thick muscle which is cut here to show the structures. If not, there will be a thick muscle called as the sternocleidomastoid, which are all anterolaterally to these lobes of the thyroid gland. One is the sternothyroid, sternohyoid, superior belly of omohyoid, as well as the sternocleidomastoid. We all are anterior to the thyroid glands or the lobes of the thyroid glands anterolaterally. Posterolaterally, if you see, so here they have removed all the muscles in the front anteriorly, and the thyroid gland itself is being lifted so that you can see the posterior relations. So what are the posterior relations? As you can see here, the thyroid, the carotid sheath. If you see here, there will be a carotid sheath containing the common carotid artery. This is the common carotid artery. Then the internal jugular vein. This is the internal jugular vein, as well as the vagus nerve. All these are together in a sheath. Sheath has been removed so that you can appreciate the different structures. One is the common carotid artery, then the internal jugular vein, as well as the vagus nerve. All these are covered by a sheath called as carotid sheath, and this will be in posterior relation to the thyroid lobes. Thyroid lobes. So this is very important relations. Okay. Now coming to the other relations medially, so here we can see here. So this is the here is the esophagus, this is the trachea, and here is the gland, the thyroid gland, covered by a sheath. Okay, fibrous sheath called as the pretracheal fascia. Pretracheal fascia because it is in front of the trachea as well as the thyroid gland. So it is called as pretracheal fascia. It's covering the whole of the gland. So on the posterior relations as we saw already. So this is the common carotid artery, internal jugular vein as well as the vagus nerve, all covered by the sheath called as the carotid sheath on either side. Okay, carotid sheath containing the common carotid artery, internal jugular vein and the vagus nerve with the sympathetic chain behind. So behind is the sympathetic chain, but these are very important relations. Okay. Then anteriorly we saw that there is sternocleidomastoid, sternohyoid, sternothyroid, omohyoid. Okay, this is the cross section of the neck where you can appreciate all the relations. Then medially, if we see now medially, we can see the larynx. Okay, so there is the trachea. In above that will be the larynx. Then we have the trachea. These are tracheal rings. Then we have the pharynx. Above that will be the pharynx. Then we have the esophagus. This is the esophagus here. Okay. Then we have the external laryngeal nerve. So there will be the external laryngeal nerve as well as the recurrent laryngeal nerve. All these nerves will be present medially. Then coming to the relations of the isthmus. Isthmus is the joining between the right and left lobe. Anteriorly, we have the sternothyroid, sternohyoid, anterior jugular vein, fascia, and the skin, as you can see here. So this is the isthmus. So anteriorly, we have the sternothyroid, sternohyoid muscles, anterior jugular vein, fascia, and the skin itself. Posteriorly, we have the second, third, and fourth tracheal rings. As we saw, it is sitting on the second, third, and fourth tracheal ring. So the posterior relation for this will be the second, third, and the fourth tracheal rings. This is the isthmus here, the isthmus. Now coming to the blood supply of the thyroid gland. It is, as we know, all the endocrine glands are highly vascular because they have to pour their secretion, that is the hormones, into the blood directly because they are ductless glands. They don't have duct, so they will be pouring their secretion, that is the hormones, directly into the blood. So that's why all the endocrine glands will be highly vascular, but the thyroid gland is still very highly vascular. Okay, it is highly vascular gland supplied by four large arteries: right and left superior left inferior thyroid artery as well as right and left superior thyroid artery. So if you can see here, so this is the superior thyroid artery on either side. Okay, on either side it is in pairs, so it is coming all the way from here, superior thyroid artery, as well as beside that is the superior thyroid vein. Okay, similarly below we'll have the, so here we have the inferior thyroid artery on either side, inferior thyroid artery on either side, which is supplying the gland. So there are two superior right and left superior thyroid artery as well as two right and left inferior thyroid. So four arteries will be supplying this gland called as the thyroid gland. The arteries anastomose with one another over the surface of the gland. As you can see here, these arteries are branching and branching and they anastomose with each other on the surface of the thyroid gland itself. Then there is also an additional artery sometimes, which is sometimes present, called a thyroidea intima artery. May be present directly from the aorta. When it comes, it is directly from this arch of the aorta. Okay, so that is called as the thyroidea intima artery. Sometimes it is present, not always, sometimes. But these four arteries are always there: superior and inferior, right and left thyroid arteries. Then it is drained by the right and left superior, middle, and inferior thyroid veins. The arterial supply is by four arteries, but the venous drainage is by six veins. One is the superior thyroid vein on either side. Then we have the middle thyroid veins. Then we have the inferior thyroid veins, So on either side. So three on right side, three on the left side. Superior, middle, and inferior. Superior, middle, as well as inferior on the right and left. Totally six veins will be drained. So there it is supplied by four arteries and six veins. Sometimes there can be a fifth additional artery called as the thyroidium artery, which is directly a branch from the arch of the aorta. Coming to the lymphatic drainage of the thyroid gland, it is draining into the deep cervical lymph nodes. As we know, all the structures in the neck, they will be finally draining into the deep cervical lymph nodes. That's why the deep cervical lymph nodes are very important, especially during examination. Coming to the nerve supply, it is supplied by the superior, middle, as well as inferior cervical sympathetic ganglion. So it is a sympathetic ganglion which will supply this gland, superior, middle, as well as inferior. There are three cervical ganglions in the neck, superior, middle, and inferior. All three will be supplying the thyroid gland. Now coming to the applied anatomy, clinical aspects related to the thyroid gland. So the two main arteries supplying the thyroid gland are closely related to important nerves that can be damaged during thyroidectomy operation. If there is excessive enlargement of the thyroid gland, okay, then you might have to remove the thyroid gland. Okay, then that procedure is called a thyroidectomy. So during thyroidectomy, even though it is present in the neck, superficially easy to remove, but it is in very close relation to very important nerves. So we should be very careful if you are doing any surgeries on that. So what are those? One is the superior thyroid artery is related to the external laryngeal nerve, which supply the cricothyroid muscle, one of the very important muscles of the larynx. So it is supplied by the external laryngeal nerve, and this external laryngeal nerve is very close to the superior thyroid artery. This is the superior thyroid artery, and if you see here, this is the external laryngeal nerve coming all the way. Okay, so external laryngeal nerve. So it is very close in relation to the superior thyroid artery is in very close relation to the external laryngeal nerve. Okay, so then the second is the terminal branch of the inferior thyroid artery are related to the recurrent laryngeal nerve. One more very important nerve which is supplying the larynx. Okay, damage to the external laryngeal nerve will result in inability to tense the vocal folds, and there will be hoarseness of voice. Then there will be bilateral complete section of the recurrent laryngeal nerve results in impaired breathing and loss of speech. So such is the importance of the recurrent laryngeal nerve. If one side is damaged, then it leads to hoarseness of voice. Then if it is bilateral damage, then it leads to impairment of breathing as well as even loss of speech. Okay, so these nerves should be very carefully handled during the thyroidectomy operations. Okay, so that's why even though it is very superficial in the neck, but removing this thyroid gland can be really dangerous. Okay, and if you are uh, very careful and if you don't block the artery, then also it can lead to lot of bleeding and even death because of the bleeding. Okay, so this, even though it looks a very simple surgery, thyroidectomy, but it is quite complicated. Then the gland is surrounded by a sheath derived from the pretracheal layer, as we saw before. So there is a sheath around the thyroid gland as well as the trachea, esophagus, everything are covered by the pretracheal fascia containing thyroid, trachea, esophagus, recurrent laryngeal nerves. Okay, so this sheath is derived from the pretracheal layer of the deep cervical fascia. The sheet attaches the gland to the larynx and the trachea. This explains why the thyroid gland follow the movement of the larynx in swallowing. As I said, there is the levator glandular thyroideae as well as even this pretracheal fascia, which is covering the gland with the, and it is connected to the larynx. So whenever the larynx moves, during swallowing, even this thyroid gland moves, and any mass coming from the thyroid gland will also move. So this is how, as I said before, you can make out whether this gland is coming from the thyroid gland or something else. Any pathological neck swelling that is part of the thyroid gland will move upwards when the patient is asked to swallow. Okay, so these are the best tests to ask for the patient to swallow. If it is from the thyroid gland, then it will move during swallowing. Okay. Now coming to the development of the thyroid gland. The thyroid gland develops as an endodermal diverticulum in the midline of the floor of the pharynx between the tuberculum impar and the cochlea. So here, this is the development of the tongue. During the development of the tongue, the anterior part, this is called as the tuberculum impar, and the posterior part is called as cochlea. And in between them, there is an endodermal thickening. Okay, so from here, actually, it is developing from the tongue, actually. Okay, then it starts descending downwards as a thyroglossal duct. So it will descend downwards and goes all the way up to the neck, and then it starts growing. Okay, then there will be formation of two ducts, and from there will be development of the gland. So the thyroid gland develops as a endodermal diverticulum in the midline of the floor of the pharynx between the tuberculum impar and the cochlea. The diverticulum grows, so this diverticulum is growing now. Okay, inferiorly in the midline of the front of the neck and is called as the thyroglossal duct. Now it is called as the thyroglossal duct. As development continues, the duct elongates and its distal end becomes bilobed. So as it elongates, the distal end becomes bilobed and it goes all the way to the neck and it starts developing. Then these remnants of the thyroglossal duct disappear. The duct becomes a solid cord of cells. Okay, and as a result of epithelial proliferation, the bilobe terminal swelling expand to form the thyroid gland. These two terminal swellings expand to form the two lobes of the thyroid gland. The thyroid gland now migrates inferiorly in the neck. By the seventh week, it reaches its final position in the relation to the larynx and trachea. So this will start descending downwards, and by the seventh week itself, it has reached already the neck. Okay. The thyroglossal duct degenerates and its site of origin marked by foramen cecum. So this whole of this duct remaining part will become remnant and it will totally disappear. And in case of the tongue, it appears, it will be present as tuberculum impar. This is it remains as the foramen cecum. The tuberculum impar will remain. So here will be this part which will be dividing the tongue into anterior two-thirds and posterior one-third, and it will be present in the center as the foramen cecum. Okay. Now coming to the congenital anomalies of this thyroid gland. Okay, one is the incomplete descent. As we saw, it will be descending into the neck. If it doesn't descend into the neck and it is on the way, then it is called an incomplete descent of the thyroid gland. Okay, sometimes it will be ectopic thyroid tissue. Sometimes it doesn't pass us through that process, but it will go to some other areas. Like as you can see here, it is going sublingual below the tongue. Okay, sometimes it is intralingual within the tongue or somewhere else. Okay, so that is ectopic. If it is not in the normal path, if it is in the normal path and has not completely descended, then it is called as incomplete descent, as you can see here in different positions. And if it is present in some other areas, then it is called as ectopic tissue or thyroid tissue. Then sometimes there can be persistent thyroglossal duct. As we saw, this whole duct will disappear, but sometimes it remains as the persistent thyroglossal duct. Okay. Sometimes it remains a small cyst. In this process, the whole duct will disappear, but there will be small cyst. So if you can see here, these are called as the thyroglossal cyst. Thyroglossal cyst in different areas where the duct has not completely disappeared, then it remains as a small cyst with small quantity of fluid. Sometimes the thyroglossal sinus fistula might appear. So there might be a hole in that through which it can start appearing. Okay. And sometimes there can be agenesis of the thyroid gland. Sometimes there can be agenesis. There can be very small thyroid gland, okay, which might have not developed. Sometimes there can be thyroglossal cyst. So, okay, so this is actually the picture of the thyroglossal cyst here. Okay, and sometimes there can be agenesis. There is no development of the thyroid gland itself. So these are some of the congenital anomalies: incomplete descent of the thyroid gland, ectopic thyroid tissue, persistent thyroglossal duct, thyroglossal cyst, thyroglossal sinus, and agenesis of the thyroid gland. Next, going to the smaller gland behind the thyroid gland, that is called as parathyroid gland. Para means beside. okay, beside the thyroid gland, so it is called as parathyroid gland. So it is actually behind. If you see, this is the picture shown of the shown the thyroid gland is shown from behind, and here you can see very small structures which are called as parathyroid bodies or parathyroid glands. Okay, the parathyroid gland, there are four ovate bodies measuring about 6 millimeters, very small, just 6 millimeters in size, and there are four in number. Okay, they are closely related to the posterior border of the thyroid gland. So that's why when we see it from behind, only then you can see. From the front, you cannot see, but if you see it from behind, then you can see these four glands. Okay, seen from they are closely related to the posterior border of the thyroid gland, lying within its facial capsule. Within the facial capsule of the thyroid gland, these glands will be present. The two superior parathyroid gland at the level of the middle of the posterior border of the thyroid gland. This is the posterior border of the thyroid gland. So this superior parathyroid will be present in the almost in the middle of the posterior border of the thyroid gland. The two inferior parathyroid gland usually lie close to the inferior pole of the thyroid. As you can see here, it is almost near the inferior pole of the thyroid, posterior border of thyroid gland. Okay, so these are the four bodies which are called as the parathyroid glands. Coming to the blood supply, it is supplied by the same blood supply, nerve supply, and even the lymphatic drainage as that of the thyroid gland, because it is closely related to the thyroid gland. So all the blood supply, venous drainage, lymphatic drainage supply is similar to that of the thyroid gland. So the arterial supply will be by the four arteries, the superior and inferior thyroid arteries on the right and left side. So it becomes four. Then venous drainage is by the superior, middle, and inferior thyroid veins, which becomes six on either side. Then we have the lymphatic drainage. It will be draining just like that of the thyroid gland into the deep cervical as well as the paratracheal group of lymph nodes. And nerve supply is slightly different from that of the thyroid gland. Here it is supplied only by the superior or middle sympathetic ganglia. There it is the thyroid gland, because it is a large gland, it is supplied by all the three sympathetic ganglia, superior, middle, and inferior. But in case of the parathyroid, it is supplied only by the superior or sometimes middle cervical sympathetic ganglia. That is the only difference. Okay. Coming to the development of the parathyroid gland, this is developing from the pharyngeal pouches. Pharyngeal pouches. Okay. So as you know, there are first, second, third, fourth, and sixth pharyngeal pouches. Okay, there are only five pharyngeal pouches. So the two superior parathyroid develops from the fourth pharyngeal pouch. As you can see, this is the fourth pharyngeal pouch, which will lead to development of the superior parathyroid. But contrastly, the two inferior parathyroid glands develop from the third pharyngeal pouch. Actually, they are developing from the third, but they descend all the way up to the inferior border. So even though they are developing from the third pharyngeal pouch, they become the inferior parathyroid gland, and the glands developing of fourth pouch will become the superior parathyroid glands. Okay, so this development you should remember. The two superior parathyroid develops from the fourth pharyngeal pouch. The two inferior parathyroid develops from the third pharyngeal pouch in association with the thymus gland. The third will be developing with the thymus gland, so the thymus gland descend downwards. So that's why even this parathyroid developing from the third will go down and become the inferior parathyroid glands. The thymus gland migrates from the neck to the thorax. It pulls the superior parathyroid to a lower level than the inferior parathyroid. So it will pull the superior parathyroid to an inferior level than the inferior parathyroid. Okay. The parathyroid becomes attached to the back of the thyroid gland. As we have seen already, it will be present on the posterior border of the thyroid gland. So it will be present behind. Okay. So this is all about the pituitary gland, the thyroid gland, as well as the parathyroid glands. So if you have any doubts regarding this, you can ask me now.
Thank you, doctor.
Everything is clear? No doubts?
Yeah, clear.